12 o'clock, so we'll go ahead and get started here. Austin, would you mind starting the recording?
Yep, we should be rolling now.
Okay. My name's Casey Shakespeare. I work with the Rural Health Association of Utah and Southern Utah AHEC. And we are thrilled to have you guys on the call with us today to talk about lupus. We're very excited to have Dr. Sara Stern as our presenter today. Dr. Stern received her medical degree from Alberta Einstein College of Medicine, and she completed a residency and a clinical fellowship in pediatric rheumatology at Children's Hospital, Los Angeles. She's currently an assistant professor in the Division of Pediatric Rheumatology at the University of Utah and Primary Children's Medical Center. And as a pediatric rheumatologist, Dr. Stern's clinical interests include juvenile, and I'm going to butcher that word, Dr. Stern, idiopathic arthritis. Is that correct? Good. And then systemic lupus. I may let you read some of the rest of those because those are words above my pay grade. But,
vasculitis, dermatomyositis, scleroderma, and autoinflammatory diseases.
Perfect. And Dr. Stern also evaluates patients for musculoskeletal and joint pain, and her current research concentrations are on chronic recurrent multifocal osteomyelitis. Is that correct?
Mm-hmm.
Pediatric Takayasu arteritis, and medical education and long-term outcomes of pediatric patients with rheumatological diseases. So as we're getting started here, we want to inform all of you that CME credit is available for today's event. The American Academy of Family Practice has reviewed our ARC Rural Health Outcomes Project Lupus Education Networking event information from today and deemed it acceptable for AAFP credit. And it will be available to get CME credit starting today until August 4th of next year. And you'll be able to claim that credit with us. We'll send a certificate out for those of you that want CME credit at the conclusion of the presentation. We do ask that prior to getting that certificate that you complete the pre and post assessment that are part of the project today on our end. And we'll talk more about that in just a second. But this is the start of today's presentation. This Rural Health Outcomes Provider Education event on lupus has been put together by the Lupus Initiative in partnership with the American College of Rheumatology. And we're very excited about the presentation today and the content that they've put together for us. And we'd like to welcome all of you and thank you for taking time to join us today. This slide deck will be available to you after the presentation, so you can read through the accreditation statements and the different items here. We do just want to point out that Dr. Stern has no disclosures of conflict of interest to report for this presentation. And as we're getting started, this presentation is part of a research project put together by the American Academy of Rheumatology. They're testing the effectiveness of the presentation. So we do ask that you complete the consent and pre-assessment before we get started here this morning, and then the post-assessment at the conclusion of the presentation. That pre-assessment was with the consent. The consent's the cover slide. Once you click that you consent, it goes into the pre-assessment. We did provide that to you when you registered, and I believe it went out again in an email yesterday. But we do want to take about 10 minutes here for anybody who has not completed that assessment to complete that assessment prior to beginning. And then again, at the end of the presentation, we will provide you the post-assessment link for you to complete that post-assessment as well, and it will go out in an email. I'm going to put that link in the chat. I'm going to stop sharing for just a moment and put that in the chat for anybody who needs to complete that still before we get started. We are going to take about 10 minutes here for anybody who needs to take that assessment. Austin, you can go ahead and pause the recording.
Wonderful. And Casey, if you'll just if anybody has any questions, you can put it on in the chat or just let me know. I want to make sure that this is a dialogue and that you guys get what you need. I feel like you guys are adult learners and you know what you need, and I hope this presentation is what you need. This is also a presentation I didn't write. It's an American College of Rheumatology presentation. If there are times where where there might be a different perspective or things might not be as clear as the slides say in general thought, I will definitely let you know. Okay, so these are the goals of the small group provider session on lupus. First, we want to build connections. We're here for you. As pediatric rheumatologists, I work really closely with the adult rheumatologists too, and they're amazing people. We understand that it can be difficult treating our patients and diagnosing our patients, and you guys are on the first, like the front lines. We so appreciate what you do and your level of expertise. And if you need anything, let us know. Second, we want to raise awareness on lupus, the signs and the symptoms of lupus. We know that lupus can appear a little bit like an enigma and an enigma. And hopefully by the end of this slide, this PowerPoint presentation, you won't feel like it's an enigma. You'll feel like it's a puzzle that you have to put the pieces together, but it's an attainable puzzle. Okay, so after this presentation, you should be able to recognize the signs and symptoms of lupus. Know when to refer to a rheumatologist or pediatric rheumatologist, and know the workup for lupus, and then have more understanding about health epidemiology and health disparities, as well as disease characteristics. So in general, lupus can take a long time to diagnose. It doesn't have to. Sometimes it's very quick, and sometimes it's a little bit more prolonged. Hopefully by the end of this presentation, you'll feel more comfortable knowing when to initiate the workup to get these patients in to see a rheumatologist quicker. So why is it so challenging? There are a couple of reasons. It can masquerade as lots of different things. I always like to say in my notes, it could be infection, it could be malignancy, it could be other autoimmunity. So it's a great masquerader, and you have to know when it's lupus and what's specific for lupus and how to diagnose lupus. Lupus is based off of criteria, but sometimes that criteria can be overlapping, such as with EBV, Epstein-Barr virus, or leukemia or lymphoma. Even some of the antibody tests can be positive. So that's why no single one tests for lupus, and you have to have a higher index of suspicion, evaluate and rule out other things, and then you can make the diagnosis of lupus. And a lot of patients with lupus have a lot of coexisting mental health concerns. And this is one of the areas that we can really use your help. So incredibly high rates of depression, anxiety, and chronic pain, such as fibromyalgia. So the symptoms can be vague, but what I want to tell you is that not all the symptoms are vague. Usually with lupus, you have a lot of vague symptoms, but then you have at least one or two usually that aren't so vague. So you have fatigue and achiness, arthralgias and stiffness, maybe low-grade fevers, maybe swollen lymph nodes and rashes. But there's characteristics to those rashes that will help you pinpoint lupus. And there's characteristics to the stiffness and the achiness to diagnose if it's just joint pain, arthralgias, versus actually inflammatory joints, arthritis. Okay. So why is this so important? The longer you have the inflammation brewing, the fire on from the inflammation in the body with lupus, the more likely you have for organ failure and death. Okay, so the quicker we can get these patients treated and their inflammation back down to normal and in remission so that the immune system starts to forget a little bit, the better that they do. And the first person they come to is you guys. So you are our front lines. We are here for you as support, but we recognize that you have a huge job to differentiate healthy from sick and figure out when somebody is sick, when to think about lupus. So our mission is to educate primary care providers about lupus so that people with lupus can get the correct referrals, diagnosis, and treatment that they need. So let's talk a little bit about lupus. So lupus, there's multiple different ways to think about it. And sometimes I think about it in different ways. And sometimes I think about multiple different aspects of lupus at the same time. I think that's what makes lupus so sort of interesting to treat. So it's an inflammatory multi-system autoimmune disease. Okay, that can have different laboratory tests and different clinical manifestations. No two lupus patients have the same stigmata. It can be anywhere from mild to severe, and then anything in between. You know, some of my most mild patients have lupus, some of my most severe patients have lupus. There's so many different organ systems that can be involved. Once again, because usually it's a vasculitis that affects the small blood vessels. Blood vessels perfuse, you know, go everywhere, the capillaries. So in general, there's more than one systems that are usually involved when you start hunting from them, but they can be silent. So even though one organ system is usually what comes to, like, one aspect of their history is something that comes to your mind, there's usually others when you start hunting. And it is characterized by periods of flare and periods of remission. I always like to tell the residents that lupus is a Roman name, Latin name for wolf. And it means wolf. You could say two things. One for the malar rash that looks like a wolf's face. But the second is that a wolf can come out of hiding very, very quickly and pounce. And then they are very good about quickly going back into hiding. And lupus definitely has that type of flare characteristics. They can be in remission for years and then boom, they come out of remission. So now let's talk a little bit about pathogenesis of lupus. I'm not that old, and even in the time since I've been in medical school, I feel like our understanding of the immune system and the component parts of the immune system has changed so dramatically. So we know lupus has characteristics of an autoimmune disease. So an autoimmune disease is when the body attacks itself, okay? That's when you talk about B cells and antibodies and T cells and all of that, okay? But when you have autoimmunity, you have the homeostasis, the thermostat of the immune system is off, okay? And then you can have immunodeficiencies associated with it and malignancies at higher rates because the immune system is too busy doing other things. I tell my patients, it's like a toddler having a temper tantrum on the floor. It just wants the banana's on the table, but it won't stop having the temper tantrum to do what it should be doing. Now we know that the innate immune system, which we used to think doesn't have any place in anything, has a lot of place in a lot of things. It's responsible for the hyperinflammatory response to COVID and MIS-C, and lupus, it definitely has a component part to lupus. So this is like the Marines of the immune system, the first responders, like the macrophages and things like that. And they cause an autoinflammatory type of syndrome and an immune dysregulation. So the police officers in lupus are not working well, and they're not tracking down when they should be getting rid of the bad cells that cause autoimmunity in lupus. We don't know why this happens. It's caused by a little bit of genetics, and maybe more in some cases, but a little bit of genetics, a little bit of environment, and a lot of bad luck. So let's talk about the demographics of lupus and the populations at higher risk. And I think that, you know, they have 4 slides in this. I know in this political climate that sometimes we don't talk about this, but in lupus, I think it's very, very important to recognize it's a pretty dramatic difference. So, it's one of the more common autoimmune diseases in the world, but it's more common in lower income populations and peoples. But women are 9 times as likely as men to get lupus. In fact, lupus predominantly occurs between menarche and menopause. Okay, if you get lupus in the littles, like my population, it's usually more severe. If you get lupus after menopause, it's more atypical. Like they tend to have more interesting arthritis and lung disease, less rashes and cytopenias. It tends to have the highest prevalence in the non-white population. So Black, Latino, Asian, American Indian, Alaskan Native. And it's not just that it's a higher prevalence. In anecdotal experience of every rheumatologist that I've ever met, it's more severe disease. Lupus affects 1 in 250 African American women in the United States, which is pretty unreal if you think of it. And African-American women are 3 to 6 times higher, have a higher risk than white women to get it. Latino and Asian American women have a higher risk than white women. We talked about that. And it tends to happen in African Americans and Hispanics at a younger age of onset. And they're more likely to die from lupus. Here's a graph to show a little bit of the difference in discrepancies of Black and white people with lupus, just so you can consider. So we know low-income individuals are less likely to receive recommended care, and poverty is associated with poor outcomes. Here's another graph about what we already talked about, just to make the point. So now let's look at some symptoms of lupus. So synovitis, which is inflammation to the joints, so arthritis. And I always like to say that any patient that presents with rheumatoid arthritis or seronegative any arthritis, you need to evaluate them for lupus, especially if there are women between menarche and menopause. You know, you get the compliments, you get the ANA, you think about lupus because it could be the presenting sign, can be the synovitis. A malar rash. So a malar rash is a butterfly rash that goes across the cheeks and the bridge of the nose. It is sun sensitive. So all of you in Southern Utah, this is the time that people come in with the malar rashes. In general, it's different than just a sunburn. It spares the nasolabial folds. Sometimes it's just red, but it's not rosacea. Usually it has some papular quality, some scaly quality, but it doesn't scar. So one of the things to tell the patients with lupus is if you take care of it, in general, malar rash doesn't scar. Painless oral ulcers. I always love to tell about my teenage girls who are like 14 years old who have these terrible oral ulcers on their posterior hard palate. In general, that's where you get them. And they're painless. And they're like, no, I have an ulcer, Dr. Stern. Take a picture and show me. And they're like, wow, that doesn't hurt at all. Now you can get ulcers in other places. You can get traditional painful aphthous ulcers, and that should be a consideration. But if a patient has ulcers that are more aphthous ulcers, you should think about other things in your differential too, such as inflammatory bowel disease, Behçet's, idiopathic aphthous ulcers, post-viral sores in their mouth, things like that. But it can be lupus. Raynaud's phenomenon. So there's a difference between Raynaud's phenomenon and Raynaud's syndrome. In general, patients with lupus have Raynaud's syndrome, and patients without a secondary autoimmune disease have Raynaud's phenomenon. What is the difference? In lupus, they actually have a vasculopathy, causing their blood vessels to get twitchy and clamp down a little bit, causing the Raynaud's. Where in a healthy population that does not have lupus, it's just due to twitchy blood vessels. How can you differentiate? In Raynaud's from lupus, usually sometimes they'll have sores at the tips of their fingers, especially in the cold weather months. They'll have capillary nail bed changes that you can look at with the otoscope, where the capillaries meet the nail bed. They can have, and if their fingers ever turn black, not deep blue, not pink, not purple, but deep black, like necrotic, that's usually that there's a secondary autoimmune disease. Discoid lupus, so it's like a disc. It usually looks like a disc. Unfortunately, these scar. Unlike the malar rash, discoid rashes scar. And of course, they're in every part of the body that a person wouldn't want to scar. So scalp, face, neck, and chest. Discoid lupus can be an isolated disease. It doesn't have to be associated with systemic lupus erythematosus, but people can start off with discoid lupus and transition into systemic lupus erythematosus, or discoid lupus could be their presenting sign. And when you do more of the workup, you actually see they have criteria for systemic lupus erythematosus. Jacob's arthropathies. This is something that is seen more in the older population. I don't see it in pediatrics. It's a very deforming arthritis caused by lupus in general. It doesn't cause erosion, so breakdown in the cartilage. Vasculitis. So when you look at one of the reasons I love being a rheumatologist, and I teach at the medical school clinical exam. So I tell everybody, like, every part of the body is important to look at when you have to look at that. And in lupus, every part of the body tells you something. So the palms are so important, right? The fingertips and the nail beds tell you about the Raynaud's, but then the vasculitic rashes, usually it's like these little pinpoint purple and deep pink, like little papular dots on the palms. And you can see that. And then alopecia. In lupus, they tend to get alopecia. It's different than alopecia areata. It's different than alopecia in like thyroid disease, where it's more diffuse hair thinning, although you can just have a diffuse hair thinning. In general, it likes to start in the frontal temporal area. So it's the same area of sort of male pattern baldness, which is exactly what these female patients with lupus love, that their hair is thinning in the frontal temporal areas. So some lupus symptoms can be more vague, but what I want you to take away from this presentation, even though they can have vague symptoms, when you do a good HPI and you go through the strategies, not all their symptoms are vague. So yes, they tend to have more achiness and headaches, more fatigue. Sometimes they have memory and brain fog and depression, but they have other symptoms. It's not just depression, brain fog, fatigue, and achiness. Okay, if it is just these four, you want to go down a different pathway, which we'll talk about. So here are some of the initial manifestations that can be a little bit more hidden. So when you feel like somebody has systemic lupus erythematosus, I'm just going to call it lupus if that's okay with everybody from now on, you can have serositis. And the criteria for lupus is pleural effusions, pericardial effusions, pleuritis, or pericarditis. And it can be completely asymptomatic, even if they have a large pericardial effusion. They can have no chest pain and no shortness of breath. It just boggles my mind, but always makes it interesting. So when you think that a patient has lupus, you get the initial blood workup back, or you just have a very high index of suspicion due to like their clinical manifestations, get a routine chest x-ray. It will show you for pleural effusions and an enlarged heart, size, and that will let us know if you can manage things more as an outpatient or they need to be as an inpatient. So everybody should get a chest x-ray. If they have an enlarged heart size, then I would get them in to get an echo soon. I know that you guys live in an area. I have a clinic in Shinley. And I know that things in your part of the world aren't as easy as walking across, down one flight of stairs and begging a cardiologist to get an echo for you. But this is the time where if you can't have them get an echo, they need to go to the local emergency room that can do an echo. Well, and then there's so many CNS manifestations of lupus. One of the things we worry the most about and can have the worst long-term effects is cerebral infarcts. Now, this can be due to antiphospholipid syndrome or just the vasculopathy of lupus. So let's take a moment and let's talk about vasculopathy, right? Because lupus is a vasculitis and a vasculopathy, because why just be one? Vasculitis is inflammation of the blood vessels. Okay, where vasculopathy is inflammatory changes to the intima, the middle part of the blood vessel, causing the actual canal of the blood vessel to become very, very thin, so that you have ischemic type changes. Okay, and in lupus, you can have both things happen. More of the vasculopathy would be like the Raynaud's in lupus, and the cerebral vascular disease if it's not from like an antiphospholipid syndrome. Brain atrophy. Now, brain atrophy has so many different reasons. Steroids can cause brain atrophy, so make sure that it's not just from steroids. Lots of blood cell changes, not just spherocytosis. And then glomerulonephritis, like kidney disease. Any patient that you have even an inkling of lupus, get a urine, look at the creatinine. So, signs and symptoms. If you look at the first 4 signs, you're like, wow, how am I ever going to tease this apart, right? Non-specific joint pains, neurologic symptoms, but the top neurologic symptoms are not stroke, psychosis, and seizures, which are in the criteria for lupus. It's more like headaches and brain fog, okay? Fevers and fatigue. But that's why lupus is based off of having at least usually 3 or 4 manifestations. So they either have arthritis or skin disease or serositis or kidney disease or blood changes of their red blood cells or platelet counts. There's something else there. And once you start doing the workup, it will become much, much more clear. So I don't like how they say, unfortunately, there is no gold standard diagnostic test to lupus. I feel like we actually get to use the expertise that we have in making clinical diagnoses and looking at the patient and doing what they need. If you put together the puzzle in the right way, you get lupus. And that's what makes it very rewarding to be able to make these diagnoses in these very sick patients. So here are the clues to suspect lupus. In the more adult, especially the elderly population, they present with arthritis and fatigue. Maybe they more likely have inflammation of their joints than other things, but I would say they present in a whole host of different ways. You want to consider other diagnoses in general. As we talked about before, could this be EBV? Could this be RA? Could this be COVID now, right? Could this be other connective tissue disease like mixed connective tissue disease and Sjogren's and scleroderma? Could it be thyroid like Hashimoto's or Graves, other skin diseases, fibromyalgia, and other things? So here are clues. They have rashes, interesting rashes, rashes that don't look like your typical rashes, rashes that make your gut go, something is not right. This isn't just eczema. Alopecia, right? Their hair thins and they have the frontal temporal pattern in general. Oral ulcers that don't hurt, usually on the posterior palate, serositis. They can have lymphopenia or leukopenia. Usually if they have these, because they're so nonspecific, especially with viral illness, you're going to want to get that on more than one occasion to say, yeah, that's from lupus and that's not just from parvovirus. And then urine, so proteinuria, red blood cells, and CAS in the urine. And remember, for I think what's important for you guys, since you live in a more rural community, is that CAS usually dissolve within hours. So if you get a urine and it has to be sent out to get the urinalysis done, you might lose your CAS, even if they have them. So ANA. Isn't it pretty? I mean, I love immune fluorescence. Maybe I became a rheumatologist just so I could look at these beautiful slides. But let's tease apart what ANAs can do and what they can't. Really, to be honest, ANAs do very little, right? They're one piece of the puzzle, okay? The majority of patients with lupus have a positive ANA, okay? But it is non-specific. It can be positive in lots of other things such as thyroid and scleroderma and idiopathic pulmonary fibrosis, or people can get ANAs without having pathologic disease. So if you are going to get an ANA, I would say I would only do it in patients that have a clinical manifestations that isn't just a vague syndrome, one of those vague 4s. Because then you have to explain to the patient or the patient's parent why you got the ANA and now why you think it doesn't matter. So ANA is anti-nuclear antibodies. So they're antibodies against the nucleus or the home cell, okay? And there are a whole host of different ones. It's the double-stranded DNA, the Smith, the centromere, lots of different ones. As we said before, and this is one of the most important things that I'm going to tell you in this lecture, in children, up to 25% of patients can have low titer ANAs without having disease. So if you get an ANA on 10 children, up to 3 of them will have a positive ANA without ever developing an autoimmune disease. They are sensitive, but not specific. And because of their low specificity, you want a high index of proper probability with other symptomatology that is concerning for lupus, and it shouldn't be a screen. And I know sometimes, once again, you're on the front line and the mom has lupus and the aunt has lupus and they're like, we need an ANA. And I would say, I never fight a parent on getting an ANA. I feel like it never works, or a patient, but I would tell them that there is a high probability that it will come back positive. That doesn't mean that they're ever going to develop autoimmunity, and it doesn't mean that they have lupus. Another thing to bring up about, if you can do the immune fluorescence ANA, it is such a better test than the ELISA. The ELISA has very high false positives and false negatives, especially when you're outside of the menarche to menopause age group. In pediatrics, I don't use the ELISA at all. It has a 40% false positive and a 40% false negative rate. It's basically flipping a coin. Okay, so if you suspect lupus, what should you get? And this is what I love. It's like breaking lupus down into simple bite-sized chunks. A lot of the simple labs that you get can help you determine if you have to look at lupus more or if you can rule it out. So a simple CBC with differential, looking for leukopenia, hemolytic anemia, or thrombocytopenia or lymphopenia, a urine protein to creatinine ratio, if there's any proteinuria, then getting a urine renal function panel, looking at the creatinine and the BUN. When you get the urinalysis, which you should get too, you want to make sure you do it with microscopy so you can get casts. Remember, if you don't get the microscopies, you don't get the casts. If there's proteinuria and it's a teenager, then you might need to do a first morning void because teenagers can have idiopathic proteinuria. We talked about the ANA, beware of the false positives. If it's positive, you want to go with the more specific tests. Sensitive tests, which, more specific tests, but they're less sensitive. So you don't even have to have a double-stranded DNA or a Smith to have lupus, but most patients have another antibody, but not everybody. Complement levels, C3 and C4, they're usually low in lupus, but they don't have to be low in lupus. If you have another, like, let's say you have a lupus patient who has an infection, infections bring up complements, lupus bring down complements, you can sort of have a normal complement. So here's a bunch of antibodies, and you can see that which ones have high specificity and which ones have sensitivity. So when should you get an ENA? When you have a high index of suspicion that this is lupus or an autoimmune disease, that an ANA would matter, like scleroderma or thyroid disease. So other labs to consider, as I said, kidney disease and CNS disease are the two manifestations of lupus that puts the disease activity in either the moderate or the high disease spectrum. So it's really important to really look at their kidneys, because if they have any kidney disease, they need treatment now, and you need to recognize that those are a patient that can go much, much more severe. You can do a 24-hour, but we really just do spots now, like a spot urine to creatinine ratio is what's widespread done, because 24 hours never seem to work. And then the CBC. If they have anemia, most anemia in lupus is due to chronic disease, okay? So you need, in order to have it lupus-related anemia, you need to get a Coombs or a DAT to look for an antibody-positive hemolytic anemia. And then we talked about the renal function, liver disease, and muscle enzymes. Okay. You can have elevated inflammatory markers, but you don't need to have elevated inflammatory markers. And in general, the ESR can be falsely elevated if they have nephrotic syndrome. Okay. And then it's always important to rule out thyroid disease. Thyroid disease is a mimicker of lupus, hyper or hypo. And then clotting. If they have weird clotting, think about antiphospholipid syndrome. And in your patient population, especially for the family docs and the internal medicine doctors, if it's a woman, like ask about their miscarriages, late term abortions, as well as blood clots, strokes, and all of that. We have made so much progress in lupus. It's an exciting time to be a doctor in the care of patients with lupus. However, we still have a lot of work to do. And unfortunately, patients with lupus still die the majority of the time of cardiovascular disease, but there's other reasons that they also pass away prematurely. An infection is one of them. We have great medicines. We know how to use them if our patients take them regularly, which can be an issue, which we can absolutely use your help with. But infections to our medications can be a big morbidity issue and mortality. The higher disease severity. So the patients who have kidney disease, pancreatitis, or brain disease, CNS disease, those are the patients that you really want to watch closely. Younger age, we talked about different ethnicities have different prevalence. Males, if they're a man and they have lupus, it's rare, but it's usually more severe too. Low socioeconomic, low adherence to treatment. And you know, I feel like having lupus, what we ask of our patients is really, really difficult. We tell them that they have to take like 9 to 12 medicines every day for the rest of their life. And usually patients have a moment where that slips. And that's where you guys can really help. Usually they will come back around. Hopefully there's not a lot of damage at that point where there's at the point of no return. Inadequate social support and limited education. So referrals early are important. And if our wait times are long, pick up the phone and call us. If you think and you have a lupus patient with a positive ANA and a double-stranded DNA and protein in their urine, we will either admit them or see them within the week. Because mortality rates are higher. Our 5-year survival in the 1953 was 50%. Before 1953, we didn't even have steroids and we didn't have cytoxin or cyclophosphamide until the 1970s-ish. And between steroids and cyclophosphamide, our survival rates sort of really increased. And then now we have so many better medications. So we have a 90% survival rate for 5 years and 80 to 90% at 10 years. And then it drops off to about 60%. And a lot of that's organ deterioration. And I think a lot of it is that our patients need constant motivational interviewing, that even though it doesn't seem like their disease is active, they still need to take their medicine. They still need to protect themselves from the sun. And every time you see a lupus patient, I would, if they're taking their medicines, and just remind them to take it, tell them, you know, that this is really hard, but they are really making a difference in their health. And the another leading cause of mortality is usually preventable when they actually are taking their medicines. So cases, how are we doing on time? Okay, we're doing fine. So which patient has lupus? I want you to just look at it. This is one that I'm a little bit ambiguous on as a rheumatologist. They say that this is more clearly lupus. However, I'm letting you know, as a rheumatologist, both patients I would be evaluating for lupus. To me, both of them have a nasolabial sparing. Yes, the one with the circle around it has a more clear rash, but to me, that looks a little bit a little bit more malar than just rosacea, has a little bit of the sun on the cheeks, like erythema on the chin. And I would look into probably both of them. Which patient has lupus? So that's the Jacob's arthropathy that's seen more in older populations presenting with lupus or having lupus. So now which patient has lupus? I'll let you guys read this and think about it to yourself for a moment, and then I'll let you know. Okay. So this is the patient that has lupus. Now let's look at the two cases and make distinguishing points. The case on my left doesn't have any distinguishing signs or symptoms. Lots of non-specific symptomatology, where the patient on the right has distinct symptomatology with vague symptoms, right? She has sores in her mouth, a rash when she goes into the sun, and swelling on her PIPs. That's sort of what differentiates the two. Whew. Okay. Now let's do another case. Is that? Yeah. Okay. So a 39-year-old woman has had swelling and stiffness in their hand joints for a year. MCPs, the big knuckles, PIPs, the big finger knuckles with morning stiffness, referred to rheumatology for suspected rheumatoid arthritis. On review of systems, you find out that they have photosensitivity. On exam, there's patchy alopecia with inflammatory arthritis. The labs show the white count is 3, the absolute lymphocyte count is 0.8 or 800. The serum creatinine is 0.6. The UA is normal. The ANA is 1 to 320 with the negative rheumatoid factor, NCCP, beta positive is Smith, a negative double-stranded DNA, SSA and SSB, and RMP. So what is your diagnosis and why? So this would be lupus. It would be myelupus with a positive ANA, leukopenia, but I would recheck it because some of those post-viral syndromes can cause leukopenia. Arthritis, a Smith, which is much more specific than the ANA, which is sensitive, and photosensitivity. I find photosensitivity very, very hard. I never like it to be like my 4th criteria in lupus unless it's very obvious. And I don't use that when they go out into, it's a rash. So it is a rash when they go out into the sun. Okay, in sun exposed areas. It's not fatigue or a headache or not feeling well. It's clinical manifestations, usually a rash, not on the malar area because you already get the malar rash, which is photosensitive. Okay. Case 2. Any questions so far? Everybody doing well? Awesome. Okay, let me know. Case 2, a 33-year-old Black woman presents with inflammatory arthritis and a positive ANA for 4 years. 1 year ago, she had a pericardial and pleural effusions, which resolved with prednisone. Now she has a fever and a cough. Her creatinine is 3.8. White blood cells is 3.4. C3, 61, C4, 9, which are both low. Her urine protein to creatinine ratio, she has proteinuria of 3.1 grams, I guess, in a 24-hour. And large blood in her urine. Her autoantibodies are pan positive. She has an ANA, a double-stranded DNA, an SSA, an SSB, and an RNP. She has other symptoms, photosensitivity, Raynaud's, pruritic rash, and oral sores. So what is the diagnosis and why? Take a moment and think about it. And if anybody has any questions, please don't hesitate to tell me. Okay, so the first thing I would say is the serum creatinine being 3.8, because once you get that back, that patient, you're calling the nephrologist and then the rheumatologist and getting them admitted to their local hospital, right? And I don't think they have the creatinine in there. I think the creatinine is even more important than the proteinuria. Not that the proteinuria isn't important. So you have a positive ANA, you have leukopenia, again, arthritis, a double-stranded DNA, which is very specific, photosensitivity, you have mucosal ulcers, renal disease with proteinuria and changes in kidney function with the elevated creatinine, serositis in the past, and low complements. Okay. Now, case 3, you have a 47-year-old woman, white woman, who comes in wanting lupus testing. She read about lupus and convinced she has it. She has arthralgias and myalgias, is tired all the time, and things have been worsening over the past year. She's not sleeping, does not feel rested in the morning. On past medical history, she has migraine headaches, no swelling joints, no rashes, no oral sores, and she has lots of tender points. So should you order an ANA, right? This is a patient that I would recommend not ordering the ANA if at all possible, because there's just, the only symptoms they have is non-specific symptoms. Yeah.
I think she needs to see a rheumatologist.
I like that one. But you could consider hypothyroidism, because that could also mimic all of that. And I think they say, which I learned in the adult population, hepatitis C is a consideration, which I know you guys see a lot more than I do in my population. Okay, so in summary to this section, early symptoms can be non-specific and easily mistaken for other illnesses, but usually when you take the history, there are things that are more specific. Symptoms may be transient or prolonged, but usually there are aspects of their course that are more chronic when you start talking to them. They have vague symptoms, but they're not the only thing. Consider it if there's a family history of autoimmunity. So this is back to the genetics question from the very beginning. In all autoimmune diseases, when you take a history, there's like a cousin that has hypothyroidism and an aunt that has rheumatoid arthritis. They don't have to have the same autoimmune disease, but they have like a problem in their police officers creating these autoimmune diseases sometimes. And then the screening labs, like simple tests in general, the complete blood count, the BNP, the liver function test, the ESR-CRP, the ANA, in general immune fluorescence is so much better than ELISA if you can do it. And a urinalysis, try to do it with microscopy if you have it. And then if you have any questions, call us, refer the patient. Of course, we would be more than happy to see them. So medications. It might not seem that way from an outpatient, but we really, really try to avoid toxicity and target organs while controlling the active disease of lupus and preventing organ damage. But it's hard. There is a difference between damage and inflammation now. Unfortunately, every time a flare happens, there is damage that happens in the body. Some of the damage can be repaired, some can't. But damage and scarring, we can't take back, whereas activity we can. So knowing where you stand, or that if this is a long-standing lupus patient, there's probably a combination of that with flare. So we use the analogy of, although we should never do this right now because we're in a drought and Utah does not want us to have campfires, but if they did, and if we had water, okay, right? You have your campfire and it's very well contained and the fire is good. It's giving you food. But then the wind comes and the fire goes into the trees, causing a major forest fire. This is a flare of lupus. And then we treat the flare with medications, which is like our water and our planes. But even when we treat it, at the end, there is still damage from the fire. And this damage no longer responds to the water or the medications the way it used to. But there's hope, because over time, you have, some of that, sometimes, most of the time, you have some recovery. The body is such an amazing thing, and you never can give up hope. Okay. So this is important as the general provider, just to to when the patient is so frustrated because the medications aren't working anymore, to talk to them about the difference between damage and activity. And that's why it's so important to stay on the medications, to talk to the rheumatologist, to get their blood work. It's such an imposition. We ask them to come to a rheumatologist, which is in a major city, right? Usually at least every 2 months, and get blood work and take medicine. I mean, the cost of lupus is unbelievable. But if they don't, it's really hard to find that activity and prevent that damage. So let's talk a little bit about medications, just so you have some familiarity with it. There was no drugs FDA approved for lupus between the years of 1958 to 2010. When Benlysta or belimumab was approved, I think in 2010 or 2011, it was all the rage because it was the first medicine that actually reached an endpoint. Why is this? This is because lupus is so different that how do you do a trial when some people, their kidney disease improves, and sometimes their rash improves, and sometimes their cytopenia improves. There are 4 drugs that have been approved for the FDA: aspirin, steroids, hydroxychloroquine, and belimumab.
Dr. Stern, we do have a question in the chat box about medication.
Yeah.
Is the longevity of males the same as females if they adhere to medication regimens, etc.?
I would say that because males in general have more severe disease than females, they have a lower mortality rate because they start off with more severe disease. And if you start off with more severe disease, you have more damage and worse things can happen. If you have a male who has the exact same disease as a female, then I'm not sure. Then it probably is similar, but I don't know if the studies have been done. Probably a little bit worse with the males, but more similar. So I think you guys know steroid side effects. I think it's important that you recognize that we know that they do a ton of terrible things and we both love and hate them. They're the only medications that work really, really quickly. And when you're trying to prevent kidney damage and scarring so that you preserve the GFR, sometimes you need them. But the biggest things that people notice, and I tell them because I always tell my patients, I want you to hear this from me. I know you're going to love them and they're going to make you feel better at the beginning, but I want you to know that I know that these are the side effects that they cause. I'm sorry, and we will work together to get you off of it as fast as we can. In general, patients are on steroids about 6 to 12 months for lupus, and some patients, it's really hard to get them off of low-dose steroids. But it causes appetite, weight gain, difficulty sleeping, and mood changes. It can increase the blood pressure. It can cause osteoporosis, advanced coronary artery disease, which they're already at an advanced rate of, cataract formation. So dose matters. So the higher the dose, the more often you give. So oral daily is more toxic than like a big dose every couple of weeks, IV. Twice a day is more toxic than once a day. Infection risk doesn't seem to be very correlative of dose. It's high. The medication, other than like chemotherapy, the medications with the highest infection risk out of all the medications we use are steroids. So if they're on prednisone and methotrexate and they get a terrible pneumonia, you guys might not know methotrexate as much as prednisone, but it's probably the prednisone causing the pneumonia, not the methotrexate. And their immune dysregulation. But not that methotrexate is perfect. It's not. So we talked about all of these. This is for your review. It can cause a lot of not great things, diabetes. But let's talk about adrenal insufficiency, because as a generalist, I think this is really important. If you're on steroids at a dose higher than in adults, I think it's 10 milligram, a dose of or higher than I think 10 milligrams per day. You can have adrenal insufficiency. So I always counsel all of my patients that if they get really, really sick and go to the emergency room, they need to let the emergency room know that they're on steroids because they might need hydrocortisone for adrenal suppression. Or if they have appendicitis and they need to be shipped off to surgery really quickly, they're probably going to need hydrocortisone. So it's important to recognize that, or they can go into shock and end up in the ICU. I think we talked about this. So one of the first medications ever used is hydroxychloroquine that we all know so well because of 2020. Unfortunately, it does not work in COVID, but it works fairly well in lupus. I don't think it does everything. In my experience, it does less than these slides point out, but that's my experience. And everybody has a different experience, but it is important. There are other medications that have been used in the chloroquine family. But hydrochloroquine is the least toxic medication with the least side effects. That's why we use it. Okay. So it's from the bark of the cinchona tree. And it was first used in lupus in 1894. But I always learned that maybe it was first used in 1894, but it became widely recognized during World War II when our troops were in the South Pacific. Everybody was using chloroquines for malarial, and patients with lupus and rheumatoid arthritis just felt better. And there's multiple hypotheses towards to why hydroxychloroquine works. In this slide is one of them. I don't think that that's as important for you, but it's really good. It's good, I should say. I don't even want to say really good. It's good at treating skin and joint disease. And prevent. Why I like hydroxychloroquine is it's an immunomodulator. It regulates the immune system. It doesn't decrease the immune system. So it has no infection risks, but it just sort of puts that immune system back in balance. What it does for my patients in general that I recognize is that if they're going to flare, it gives me a little bit more time, and the flare is a little bit more mild. So it gives us a little bit more time, and it's good at treating skin and joints. And you can see that studies have been done to show that patients that are on hydroxychloroquine do better than when they're not on hydroxychloroquine. And the cool thing is hydroxychloroquine is one of those medicines that are safe in pregnancy. So it's a difficult time, but there's a lot of really, really exciting research being done on lupus women getting pregnant and having safe and healthy pregnancies now, which is wonderful because we want them to live as full of a life as they can. And hydroxychloroquine is one of those safe medicines. The biggest concern is retinal toxicity. In general, very rarely do any of our patients have retinal toxicity. It's usually at much, much higher doses. But how it works is like the body becomes oversaturated with hydroxychloroquine, and you get these deposits in the retina. So they're these fancy computers that the Moran Eye Center has and some other ophthalmologists have that look and can see if it's depositing, and we stop them before there's even changes. If not, and you don't have access to those really awesome computers, then the ophthalmologist should do visual field tests and color tests, because you lose your yellow, blue color vision and your peripheral vision first with hydroxychloroquine. Azathioprine is another medicine that can be used in lupus, and one of the reasons why it's next is that it is safe in pregnancy, can be used for lupus nephritis. In general, we don't use it as our first line in most lupus nephritis patients with severe disease, but if they have more mild lupus nephritis, it could be something we use. The important thing to know is that your body makes enzymes, the TPMT enzymes. Some people don't have them. It's 5% of the population. If you give somebody azathioprine that don't have one of these enzymes, they can have a terrible hemolytic anemia, and they could end up in the hospital. So mycophenolate mofetil is one of our gold standard. It works for kidney disease. It's good for cytopenias. It's not as good for arthritis, but it's not recommended in pregnancy. I think that one of the things that we really need your help with is making sure that all women with lupus have a good form of progesterone-only birth control. So either the IUD or the Nexplanon are the best methods, especially now. And so mycophenolate mofetil, if a woman gets pregnant on this medicine, their baby can be born without a face. That's a big deal. And so it's really important to be able to give them anticipatory guidance and get them with a long-standing great birth control method so that they, once again, can live their full life without having to worry. And when they're ready to have babies, they go to a high-risk OB and the rheumatologist. They get taken off the cell set for around 3 months, put on like something like azathioprine and hydroxychloroquine if they're stable enough to handle it. And then they go off and have, usually usually they do much better. Cyclophosphamide is a derivative of mustard gas. It's a chemotherapy. It has a lot of side effects, but sometimes the patients need it because lupus has a lot of side effects. Because of the other medications we have in our armamentarium, we only use it when we really, really need it. But it does, it can cause infertility, but I've definitely had patients get pregnant after cyclophosphamide, so I try not to overstate that. It's teratogenic. It can cause bladder cancer and blood cancers and hemorrhagic cystitis. We try and use only as much as we need and transition them to something else. We're very creative in our ways to get them off of it as fast as we can, but sometimes they need it, especially if they have CNS disease. Methotrexate, so that's one of our gold standard in arthritis. Methotrexate has been around longer than ibuprofen. Ibuprofen came to the market in 1980. Methotrexate has been around since the 1970s. I always like to tell my patients that because we do have a lot of great data on methotrexate. And it's a great arthritis medicine, arthritis, general arthritis, inflammatory arthritis, and arthritis and lupus. So what are our complications in general of our immune suppressants? So infection, and that's where you guys are on the front line because they call us and we say, please go to your primary care provider and get evaluated. And their infections can be so atypical. I had a lupus patient come in on cyclophosphamide. She had a ruptured appendicitis with a normal CRP and ESR. And none of the typical findings. And so by the time she actually got the imaging, it were ruptured. So it's really important to recognize that the patients are going to come in due to their immune dysfunction and their immune suppression with very atypical presentations. And from the infection standpoint, if you're thinking about it, test. Okay, there's no overdoing it in lupus. Okay, cancer, especially leukemia and lymphoma, but if they've been on like Cytoxan, bladder cancer, lots of other cancers, infertility, and teratogenicity. So biologics. So we talk about the biologics, really, belimumab is the only biologic approved and used in lupus as widely spread. Sometimes we use rituximab, but what is it? So basically, it's a medication based on a living organism. So it's usually an antibody or a receptor to an antibody. Yeah. So our first FDA-approved medication, belimumab, it doesn't do great things for CNS disease or kidney disease, but people who have cytopenias or arthritis or skin disease, belimumab works better, and it works really well in conjunction with other medications. In fact, at our last national meeting, they showed us a study that showed that patients that were on belimumab with another medicine like Cellsact or things or mycophenolate mofetil, the belimumab patients had a lower rate of a decrease in GFR. So their GFR was more stable than patients not on belimumab. And I thought that was pretty awesome because at the end of the day, we want to save kidney function, right? But it's expensive. But lupus is expensive. Taking care of lupus is expensive. Hospitalizations are expensive. If it can get the patient so that they're not on dialysis 3 times a week and need a kidney transplant, I think it's worth it. Once again, it's only an additive medicine for renal disease. This shows you that having lupus is expensive. Even when it's cheap, cheaper medicines are expensive and biologics are very expensive. So giving them assistance programs, there's assistance programs if they need help. The GoodRx is a great opportunity. If they want to go to one pharmacy, they might want to go to the other pharmacy because the medications are half the price, but I know you know this more than I do. UV, so what can you guys do and what are the non-pharmacological interventions that you can give them anticipatory guidance when they're there? So UV protection. Lupus patients should not be out in the sun during peak sunlight hours, which is generally between 10 and 4, but that was data that I got from LA. We know that our nights, in summer go very late and the sun is very bright. So they really should minimize their sun exposure time to an hour to 2 hours at the max. They should wear wide brimmed hats, long sun sensitive shirts and pants, and reapply sunscreen with at least 40 SPF with UVA and UVB protection every 1 to 2 hours. And then they shouldn't have live virus vaccines. Smoking increases your risk of severity and developing lupus. We have to monitor their lipids, their blood pressure, and their bone density. Make sure that they have their standard immunizations, birth control, and getting them up and moving. So this is where we can use your help because we don't do quite as good of a job as you guys do. All lupus patients should have the pneumococcal conjugate 13-valent vaccine, the Pneumovax, and the influenza. What's contraindicated? Live virus vaccines, right? MMR, varicella, yellow fever, and flu mist. Oh, zoster. How could I forget zoster? So now let's talk about a couple of cases. 19-year-old woman with a new diagnosis of lupus nephritis presents with anasarca and an elevated BP, excuse me. Other findings, they have leukopenia, lymphopenia, Coombs positive, thrombocytopenia, nephrotic range proteinuria and hematuria, a positive ANA, double-stranded DNA, low C3 and C4. They're diagnosed with class 4 lupus nephritis, which is DPGN, the most severe lupus nephritis, okay? Even though there's 5, that's membranous, it's very proteinuria, lots of protein in the urine, but better, actually, easier to treat. And class 6 is sort of a dead kidney, like a scarred off kidney. So this patient has lupus nephritis in a 19-year-old woman. You want to treat them aggressively, but we always are trying to reduce their steroids and prevent long-term damage. So they're going to have steroids with immunosuppressive therapies, usually at least 12 months of steroid. With a 19-year-old with class 4 lupus nephritis, we're probably maybe not going to get them off steroids at 12 months, but we hope. On blood pressure control, they're going to need an ACE and an ARB for proteinuria. And just another shout out for you guys that use the ACE and the ARBs. You know that that's a huge teratogen. So anybody on any ACE and ARBs needs a permanent form of birth control, like that really help them. If they have diarrheal illnesses, they need to hold their ACE or ARB or their creatinine can spike. And then a use of contraception. So 51-year-old man presents with arthralgia for 3 years. He comes to the rheumatologist. He doesn't have any major organ system involvement, but he has bilateral 2nd and 3rd MCP swelling. The rest of the exam is unremarkable. So you're going to do the rheumatoid arthritis evaluation. The RFP and CCP was negative. ANA is positive with a dual pattern, speckled and homogeneous. Both of them go with lupus, but at a low to moderate titer ANA of 1 to 320. The double-stranded DNA, which is specific, is positive. The SSA and SSB is positive. The Smith and RNP are negative. What medications would you recommend? So in this patient, you could start off with hydroxychloroquine. In my lupus patients, which aren't, a 50-year-old has more immunosuppressive aspects and they get more infection. So you could just start off with hydroxychloroquine, or you could add methotrexate. I might add methotrexate, but that's just me. And a prednisone taper. And when they get off the prednisone, then you can examine them. If they have any problems or concerns, then you can add more. On his repeat labs, he has a white count of 4.9, an absolute lymphocyte count of 900. Remember, some of our medicines, once you start them, cause a low lymphocyte count. No anemia or thrombocytopenia. The C3 and C4 are normal. The UA and the creatinine are normal. So in this case, we diagnose lupus based on the ANA, the double-stranded DNA, lymphopenia, and arthritis. They have mild disease, and we talked about the treatment. So in summary, lupus is a very heterogeneous genus disease with multiple different presentations and treatment. But if you break it apart, you can really see what's happening. The goal is to minimize medication toxicity when considering corticosteroids, and understand the pathogenesis of lupus leads to more targeted therapy. Okay. Now, What in the last 10 minutes, we're going to talk about health, maintenance, and prevention. Okay. This is what we really would love for you to do. Remember, lupus patients have higher rate of coronary vascular disease, infections, and osteoporosis. They need their preventative care, and you are much better at than we are. We're rusty. We don't do it all the time. You are the experts, and we really appreciate it. Vaccines are important. Low dose aspirin is a little bit controversial, whether it prevents clots or not prevents clots, just like in the over 50 population. I would defer to what the individual rheumatologist tells the patient, and cholesterol monitoring. And remember that more severe disease happens in younger patients, uninsured patients, and patients that don't have primary care doctors, which is a lot of our patients. So know the risk factors for premature coronary artery disease. We'll talk about osteoporosis and vaccines. So basically the gestalt of this slide is if a patient has hypertension, we need to treat it. Okay. And I would work with the rheumatologist or the nephrologist to find the best treatment. And if a patient has proteinuria, an ACE inhibitor or an ARB really does help with the proteinuria. I'd work with the nephrologist or the rheumatologist, depending on who is sort of controlling the kidney disease, to help you manage that. But if they're vomiting or having diarrhea, they need to hold their ACE or their ARB, or their creatinine can skyrocket, and they need to be on a birth control if they're a woman. Discuss about contraception. I think this year, this is more important than ever before. Progesterone only long-term birth control. We want healthy moms and healthy babies at the right time, but all lupus patients are at high risk. They're at high risk for death in pregnancy. They have late-term miscarriages. Their disease can flare. And they have higher rates of things like preeclampsia and HELLP syndrome. If a patient has lupus, then you really want to talk to them about smoking, their blood pressure, their BMI, diabetes, and their lipid panel. And I always BMI is definitely something that over the course of my career, I've changed how I viewed it. You know, when you put somebody on steroids and then ask them to lose weight, that's almost impossible. I try to talk about healthy lifestyles and doing the best that they can. So pneumococcal vaccine, and the influenza, if in general, they should have it. There's very few reasons not to. If they didn't, and the rheumatologist didn't recommend it, most of the time it's because we forgot to tell them or had too much other things to do. Bone density testing and osteoporosis. So this slide, oh, there we go. If they're on steroids for more than 7.5 milligrams for more than or equal to 3 months, at some point they need a bone density testing. And if they are on that same dose, they need supplemental calcium and vitamin D. And if they have a history of a pathologic fracture or a T-score equal to less than -2.5, they probably should be on some agent to help with bone strengthening unless they refuse or it's contraindicated. So if you need more information, please don't hesitate to reach out. Once again, I think our partnership, our patients so appreciate it, and it's important. What you guys do is really important. So you guys can take the post-test at your leisure. Does anybody have any questions in the last few minutes?
Yeah, as we're asking those questions, the post-test link is in the chat box. I'm also sending an email to everybody that's got that post-test link in it, and the copy of the slide deck. We do need to have you complete that post-test for our portion of the project. So we ask you, please do take the time to complete that post-test, and then we will send your CME credit after we receive your post-test and your pre-test. So once we have those post and pre-assessments, we will send you a certificate for the CME for today's presentation. We will take time for questions. You can take the post-test now if you're available to stick around for a few minutes, and while we're hanging around for about 5 more minutes, any questions that you guys have. There were a couple that didn't get answered.
Oh,
in the chat box. Well, mostly just one. Can lupus affect fertility?
so really great question. In rheumatoid arthritis, that we were starting to have more data. Okay. In rheumatoid arthritis, what we know in inflammatory arthritis is that in general, women have problems getting pregnant. So they have problems with fertility and they have more infertility. In lupus, in general, they can have fertility issues, but most of the time they have late-term miscarriages, especially if they have things like antiphospholipid enzymes. Yes and no. But they can have sort of severe outcomes and their pregnancies really need to be monitored.
Mhm.
And they have, once again, higher rates of HELP, eclampsia, high blood pressure, even if they don't have kidney disease, which is sort of crazy.
And Dr. Stern, if you want to advance the slide, one more slide, there's actually a resource manual here for lupus as well. If you guys want to jot down that information as well. And do we have any other questions?
But it is an exciting time.
Well, I
For
think-
lupus patients to get pregnant, and the lupus patient is pregnant that they can call and become part of it to be a little bit more to get a little bit of a closer view with like some national experts that are focused on.
And with that, I think we'll end there. Dr. Stern's contact information is in the slides. We really appreciate you guys taking the time to attend today and be a part of our presentation. And we want to thank Dr. Stern for her time as well. It was an excellent presentation. We really appreciate you being here with us today, Dr. Stern.
Oh, anytime. Thank you, everybody.